Epstein Barr virus. Epstein Barr virus, EBV or human herpes virus causes infectious mononucleosis and is latent in most adults. Epstein Barr virus, EBV, is a virus in the herpes virus family that can infect humans. EBV infections are very common. You may have already contracted the virus without even knowing it. The condition that you may associate EBV infection with is infectious mononucleosis, or mono. However, experts are researching potential links between EBV and other conditions, including cancer, autoimmune diseases, and long COVID. EBV is commonly transmitted by infected saliva, hence the nickname the kissing disease. Primary infection involves epithelial cells of the oropharynx and parotid gland. Viral shedding occurs for weeks to months after infection. Following replication in epithelial cells, EBV infects B cells and quickly becomes latent. Latent EBV is a factor in the development of nasopharyngeal carcinoma, Burkitt's lymphoma, and other lymphoproliferative disorders in immune-compromised individuals. As it has been known for years that cells and tissue culture could be immortalized by EBV, we now realize that EBV is the prototypic gamma herpes virus and is oncogenic in humans. The Epstein Barr virus is responsible for infectious mononucleosis syndrome and is also closely associated to several types of cancer. The main complication involving Epstein Barr virus infection, both in recipients of hematopoietic stem cells and solid organs, is post-transplant lymphoproliferative disease. The importance of this disease has increased interest in the development of laboratory tools to improve post-transplant monitoring and to detect the disease before clinical evolution. Viral load analysis for Epstein-Barr virus through real-time polymerase chain reaction is, at present, the best tool to measure viral load. However, there is not a consensus on which sample type is the best for the test and what is its predictive value for therapeutic interventions. Epstein-Barr virus, EBV, is classified in the family Herpesviridae, subfamily Gamma herpesvirinae, genus Lymphocryptovirus and species human herpes virus. Sequencing-based studies revealed the existence of two types of EBV. It is estimated that this ubiquitous virus has infected more than 90% of the world's population. According to the Center for Disease Control and Prevention, Atlanta, USA, 95% of the adult population between the ages of 35 and 40 are carriers of EBV. EBV transmission occurs mainly through contact with oropharyngeal secretions containing the virus. Nevertheless, it can also take place through blood and blood derivative transfusions and through organ and tissue transplantation. Breast milk may also contain the virus, but this is an uncommon route of vertical transmission. Additionally, EBV is also present in genital tract secretions. In developing countries, primary EBV infection usually happens during childhood in an asymptomatic or clinically nonspecific manner. In developed countries, however, it is more common for the primary infection to occur during adolescence or adulthood. It can result in the development of classical symptoms of infectious mononucleosis syndrome, IM. Studies suggest that this may be explained by the amount of virus introduced in the body. What causes mononucleosis, mono? Over 90% of mono cases are caused by the Epstein-Barr virus. Other viruses and certain infections may also bring on the illness. The symptoms can develop because of 1. Adenovirus, 2. Cytomegalovirus, CMV, 3. Hepatitis A, Hepatitis B and Hepatitis C, 4. Herpes simplex virus, HSV, 5. Human immunodeficiency virus, HIV, 6. Rubella, 7. Toxoplasmosis. Symptoms of EBV. EBV infections don't always cause symptoms. This is especially true for children. Teens and adults are more likely to experience symptoms, which can include fever, feeling tired or fatigued, headache, sore throat, swollen lymph nodes in your neck or underarms, swollen tonsils, enlarged spleen, splenomegaly, or swollen liver, body aches, skin rash. These symptoms can last for 2 to 4 weeks, though feelings of fatigue may linger for weeks or months. If you have an enlarged spleen, doctors may recommend restricting contact sports until you fully recover to prevent rupture. How does the virus spread? EBV spreads from person to person through bodily fluids, particularly saliva. This is why mononucleosis, one of the most well-known EBV infections, is casually known as the kissing disease. But you can also get the virus by sharing personal items, such as toothbrushes or eating utensils, with someone who has an active EBV infection. EBV can also be spread through blood and semen. EBV can start spreading to others as soon as you contract it. This means you can pass it on before you even start to have symptoms of an active infection. You'll be able to pass EBV on to others as long as the virus is active, which could be weeks or even months. Once the virus becomes inactive, you can no longer spread it to others, unless it reactivates. Diagnosis of EBV. Diagnosing EBV infection can be challenging because the symptoms are similar to other illnesses. EBV infection can be confirmed with a blood test that detects antibodies. About 9 out of 10 of adults have antibodies that show that they have a current or past EBV infection. Treatment of EBV. There's no specific treatment or vaccine for EBV. And because they're caused by a virus, EBV infections don't respond to antibiotics. Instead, treatment focuses on managing common symptoms. This includes getting enough rest, drinking plenty of fluids, taking over-the-counter pain relievers to ease fever or sore throat, avoiding contact sports or heavy lifting. Complications of EBV. In some cases, EBV infections can lead to complications, some mild and some serious. These include rupture of the spleen, anemia, low platelet count, thrombocytopenia, hepatitis, myocarditis. Conditions affecting the nervous system, including encephalitis, meningitis, and Guillain-Barré syndrome. If you suspect you may have an active EBV infection, it's best to see a doctor if you are concerned about your symptoms. They can monitor you for signs of complications and tell you what to look for as you recover. Symptoms of reactivation. Once you've contracted EBV, the virus remains inactive within your body for the rest of your life. This is called latency. In some cases, the virus can reactivate. In many people, it does not usually cause symptoms. But in others, it can cause chronic or serial infections. Reactivated EBV may cause symptoms similar to those of an initial EBV infection in people who have a weakened immune system. EBV reactivation and COVID. EBV and COVID-19 are caused by different viruses. However, a research study from 2021 and another from 2022 suggests that inflammation caused by COVID-19 may cause EBV reactivation in some people. Some people hospitalized with COVID-19 were also found to have reactivated EBV as well. Long COVID, also known as post-COVID-19 conditions, and EBV reactivation have many symptoms in common. The above studies suggest that EBV reactivation may cause some of the symptoms of long COVID. It's important to note that EBV is not the only health condition associated with long COVID. Having type 2 diabetes or certain antibodies associated with autoimmune diseases such as lupus and rheumatoid arthritis may also be linked to developing long COVID. A high viral load, or the amount of the virus in your blood early in the infection, is also considered a risk factor. Additional studies are still needed to better understand the link between EBV and long COVID. Chronic EBV. In very rare cases, EBV infection can lead to a chronic condition called chronic active EBV, CAEB. CAEB is characterized by ongoing symptoms and blood test results that show an active EBV infection. CAEB starts out as a typical EBV infection. However, some people's immune systems aren't able to control the infection, allowing the active virus to linger instead of going dormant. Symptoms of CAEB can include swollen or tender lymph nodes, fever, enlarged liver, hepatomegaly, or spleen, splenomegaly, fatigue, sore throat, headache, muscle pain, joint stiffness, anemia, liver failure. Experts aren't sure why some people develop CAEB, but they believe genetic factors or mutations in EBV-infected cells may play a role. In addition, CAEB is more common in Asia, Central America, and South America. CAEB. Currently, the only effective treatment for CAEB is a hematopoietic stem cell transplant. Over time, CAEB can cause several complications, including a weakened immune system, lymphomas, leukemia, Hemophagocytic syndrome, a rare immune disorder, organ failure. Can EBV cause cancer? EBV infection can increase the risk of developing certain rare cancers. This is because mutations in cells infected with EBV can lead to cancerous changes. According to the American Cancer Society, some types of cancer that may be associated with EBV include nasopharyngeal cancers, or cancers in the back of the nose. Certain types of lymphoma, including Burkitt's lymphoma, Hodgkin's lymphoma, gastric adenocarcinoma, stomach cancer. EBV-associated cancers are uncommon. Most people who have had an EBV infection will not go on to develop one of these cancers. Experts are still trying to identify these specific mutations and why EBV infection seems to cause them. But overall, it's estimated that EBV infection contributes to only about 1% of cancers worldwide. EBV-related diseases. Infectious mononucleosis. IM usually occurs during adolescence or adulthood but can occasionally affect children and the elderly. Also known as the kissing disease, it is commonly a self-limiting disease, which means it evolves to a cure without specific treatment. In 80% of the cases, there is the presence of heterophile antibodies. Also, in the complete blood count, it is possible to see leukocytosis with high lymphocytosis and the presence of Downy cells, atypical lymphocytes. These lymphocytes have an enlarged cytoplasm and condensed nucleus. They are primarily T cells acting on the eradication of B cells infected by EBV. Hodgkin's lymphoma. There is a strong association between Hodgkin's lymphoma, HL, and EBV infection, although its role in this disease's pathogenesis is not fully clarified. The virus has been found in around 40% of HL tumors. Cases in children and the elderly are generally associated with EBV, while adults with HL are more frequently EBV negative. Non-Hodgkin lymphoma. Although overall non-Hodgkin lymphoma, NHL, rates are high, there is a great variety of types of these lymphomas and a variation of incidence between countries. In general, only 5% of the tumors are EBV positive. This ratio rises up to 40%, however, in AIDS-related cases. Enlarged cervical, axillary and/or inguinal ganglia, excessive nocturnal sudorisis, fever, itchy skin and weight loss without apparent reason must be investigated by the physician. Burkitt's lymphoma. At present, Burkitt's lymphoma, BL, represents a subset of NHL and is a type of tumor composed of small malignant B lymphocytes. It can be classified in two types, endemic and sporadic. In the endemic type, there are three factors that contribute to its development: malaria, EBV, and the expression of the c-MYC gene. The disease affects children in Equatorial Africa and New Guinea, malaria endemic zone, and frequently the tumor starts in the jaw. It is known that malaria causes T-cell immunodeficiency, reducing the control over the proliferation of EBV-infected B cells. Over 95% of African patients with BL were previously infected by EBV. In the sporadic variant of BL, although histologically similar to the endemic form, only between 20 and 30% of tumor cells carry the EBV genome. It is important to note that, in the age-related sporadic variant, 30 to 40% of the tumors are EBV positive. Post-transplant lymphoproliferative disease. Post-transplant lymphoproliferative disease, PTLD, occurs due to the iatrogenic suppression of T cell functions and is characterized by an abnormal proliferation of B cells. The main risk factors are 1. Post-transplant primary infection, 2. Previous splenectomy, 3. Second transplant, 4. Patient age. 5. Acute or chronic graft versus host disease, GVHD, co-infection by cytomegalovirus or other viruses. 6. Regimen and intensity of immunosuppression therapy, use of anti-thymocyte globulin, ATG. 7. T-cell depletion. 8. Transplants with HLA disparity and 9. EBV-negative recipient with EBV-positive donor. The use of umbilical cord blood as a source of cells for allogeneic transplants also increases the risk of PTLD. Explanations include the low quality of T cells from cord blood, donor-recipient HLA incompatibility and/or partial compatibility and the use of ATG. PTLD pathogenesis differs between hematopoietic stem cell transplantation, HSCT, and solid organ transplantation, SOT. As immunosuppression in SOT has to be maintained throughout the patient's life, there is a constant risk of PTLD. The incidence varies according to the transplanted organ. The following rates are reported: intestines and multiple organs, 11 to 13%, lungs, 2 to 9%, heart, 2 to 6%, liver, 1 to 3%, and kidney -1%. One explanation may be related to the type and intensity of the immunosuppressive regime. A multicentric study of 26,901 patients submitted to HSCT suggested a high rate of PTDL in over 50-year-old individuals and also in patients submitted to a second transplant. Other risk factors were also taken into consideration, such as T-cell depletion, partial HLA combination, and acute or chronic GVHD. The study in question divided the patients in 4 groups and calculated the disease rates. Individuals without important risk factors, patients with 1, 2, or more risk factors. The incidences of PTLD were 0.2, 1.1, 3.6 and 8.1%, respectively. The highest frequency of this complication occurs in children and it is often reported during the first year post-transplant with a high incidence during the first 6 months. It can also happen later, however, as late as 10 years after the transplant. The disease encompasses a great diversity of pathological conditions that often makes the development of a standard classification system difficult. T and B cells. There can be a predominance of monomorphic or polymorphic T and B cells. It can present itself as a self-limited lymphoproliferation or as a fulminant disease, and be localized or of ample dissemination. Despite the variance, the World Health Organization, WHO, recommends its classification in 4 categories. A. Initial lesions. B. Polymorphic PTLD. C. Monomorphic, lymphomatous, PTLD. D. Classical Hodgkin's lymphoma type PTLD. There are several forms of treatment. Interventions can be preventive, or start at the moment of identification of a probable or proven EBV-caused disease. Treatment is based on the reduction or removal of the immunosuppressive therapy. The use of anti-CD20 antibody, rituximab, antiviral drugs and, when necessary, conventional anti-neoplastic therapy. A recent review showed that a single dose of rituximab was efficient to prevent PTLD. Although many studies certify the efficiency and safe administration of this therapy, it is important to say that one of the limitations of anti-CD20 is its specificity for B cells, infected or not, causing a systemic reduction in this cell population and hypogammaglobulinemia. Prophylactic use of antiviral agents has been discouraged due to the lack of efficiency. Ganciclovir and acyclovir can reduce EBV replication, but these are not active in PTLD. The role of passive immunization with the intravenous anti-CMV antibody remains uncertain. In a study involving renal transplant patients, the use of anti-CMV4 was beneficial in the first year after transplant. A promising treatment is the use of EBV-specific cytotoxic T lymphocyte infusions cultivated from samples of the recipient in SOT and from the donor in HSCT to prevent and treat PTLD. The confirmation of the disease requires biopsy tests and histological analysis. Notwithstanding, viral load analysis is paramount for post-transplant monitoring. Besides the measurement of virus load, the demand for alternative assays to evaluate PTLD risk increases every year. Tests to quantify EBV-specific T lymphocytes are proving promising. It is important to remember, however, that there are EBV-negative PTLD cases. These are rare and common in late-onset cases, 50 months post-transplant on average. In such situations, viral load assays for EBV will not detect PTLD. According to Moody et al., around 30% of late-onset cases present a pattern of EBV-negative lymphoma. Nasopharyngeal carcinoma. This disease has its highest incidence in the south of China, where it represents around 20% of all cancer cases in adults. It is also found in Northeast Africa and among the indigenous peoples of Alaska. In Europe and North America, incidence rates are lower than 1/100,000th inhabitants. Over 99% of the cases are EBV-related and the viral genome is found in modified epithelial cells. Tests on DNA extracted from these cells revealed that all the cases in areas of high, intermediate and low incidence were consistently EBV positive. Can EBV cause other health conditions? EBV may also play a role in the development of other health conditions, including autoimmune disorders and schizophrenia. Autoimmune disorders. EBV has long been thought to be linked to autoimmune disorders, such as lupus. Experts believe that EBV may cause changes in the way some genes are expressed. This altered gene expression could increase your risk of developing an autoimmune disorder. There was a 2018 study supported by the National Institute of Allergy and Infectious Diseases and other NIH components. It found a potential link between EBV and an increased risk of developing lupus, an autoimmune condition. The study's authors believe that same mechanism linking EBV and lupus may also link EBV to other autoimmune conditions, which can include multiple sclerosis, rheumatoid arthritis, celiac disease, type 1 diabetes, inflammatory bowel disease, juvenile idiopathic arthritis, thyroid autoimmune diseases, including Hashimoto's thyroiditis and Graves' disease. They suggest that EBV may activate certain genes that can affect your risk for developing autoimmune disease in combination with other factors. Still, more research is needed to fully understand the potential link between EBV and autoimmune conditions. Schizophrenia. A 2019 study looked at rates of EBV infection in more 700 people both with and without schizophrenia. Those with schizophrenia had higher levels of antibodies to some EBV proteins than those who didn't, suggesting they had an unusual immune response to the virus. The researchers also found that participants with genetic risk factors for schizophrenia as well as elevated antibodies were over 8 times more likely to have schizophrenia than the control group. A smaller 2021 study led by the same researcher found that in 84 individuals with schizophrenia, having a higher amount of antibodies was associated with a lower cognitive performance. The study's authors suggest that EBV exposure may contribute to cognitive deficits in people with schizophrenia. Further research is needed to study a possible link between EBV infection and schizophrenia. Can mononucleosis recur? I thought that once you got mono you couldn't get it again. Most people who have infectious mononucleosis, will have it only once. But rarely, mononucleosis symptoms may recur months or even years later. Most cases of mononucleosis are caused by infection with the Epstein Barr virus, EBV. Once you're infected with EBV, you carry the virus, usually in a dormant state, for the rest of your life. Sometimes, however, the virus may reactivate. When this happens, you're not likely to become ill. Rarely, reactivated EBV may cause illness in people who have weak immune systems, such as those who have AIDS. Mononucleosis rarely leads to a serious condition called chronic EBV infection. In chronic EBV infection, you have long-lasting symptoms and a viral infection that lasts longer than usual after your original mononucleosis diagnosis. If you're experiencing signs or symptoms of mononucleosis, such as fatigue, weakness, fever, sore throat and swollen lymph nodes, and you've had mono before, talk to your doctor. He or she can determine the cause of your current symptoms. Hepatitis and toxoplasmosis. Keep in mind that many other conditions, such as hepatitis and toxoplasmosis, can imitate the symptoms of mononucleosis. How can I prevent mononucleosis, mono? There's no vaccine for mono. The best way to prevent getting the viruses that cause mono is by practicing good hygiene. Don't share foods, drinks or bodily fluids with someone who has mono or any signs of viral illness, like fever, cough, sore throat or fatigue. Is mononucleosis, mono, contagious? Viruses that cause mono are very contagious. You can pick them up through contact with an infected person's bodily fluids, including saliva. These viruses spread through blood transfusions, coughing or sneezing, kissing, sexual contact, sharing food, drinks or eating utensils, organ transplants. How is mononucleosis, mono, managed or treated? There isn't a vaccine or cure for mono. Antibiotics to fight bacterial infection and antiviral medications to kill other viruses don't work against mono. Instead, treatments focus on helping you feel better by relieving symptoms. Your care might include rest. Mono makes you very tired. Sleep helps your body fight infection. Hydration. Drink plenty of fluids to prevent dehydration. Pain relievers, non-steroidal anti-inflammatory drugs, NSAIDs, ease fever, inflammation, headaches and muscle aches. These drugs include ibuprofen, Advil, and naproxen, Aleve. Acetaminophen, Tylenol, also works. Sore throat soothers. You can gargle with salt water and use throat lozenges. Avoiding sports. Physical activity can put too much pressure on an enlarged spleen, increasing the risk of rupture. You should avoid contact sports and strenuous exercise while you're sick and for up to 4 weeks afterward. What are the complications of mononucleosis, mono? Mono symptoms tend to gradually improve in about 4 weeks. Feelings of fatigue can linger for months. Some people miss some school or work as they recover. An enlarged spleen that ruptures, bursts, is the biggest concern with mono in previously healthy individuals. This gland in the upper left abdomen, belly, helps filter blood. If your spleen bursts, it can bleed into your abdomen. Internal bleeding from a ruptured spleen can be life-threatening and requires emergency surgery. Your healthcare provider may tell you to avoid strenuous exercise, contact sports and heavy lifting until you feel better. How does mononucleosis, mono, affect pregnancy? Expectant moms who develop mono from EBV typically have healthy pregnancies. Call your healthcare provider if you develop a fever, which can increase the risk of miscarriage and premature labor. While there's a slight chance you may pass the Epstein Barr virus to your baby during pregnancy or after childbirth while breastfeeding, most babies don't develop mono symptoms. If mono was caused by a CMV infection during pregnancy, there is a chance your infant may be affected and you should discuss this with your obstetrician.